Good afternoon, all. I am Dr. Monica Shashank, Medical Director at DrBLalLab Clinical Laboratory. I extend a warm welcome to you all in this webinar under the umbrella of Doctor. DrBLalLab Clinical Laboratory has always been pioneer to introduce novel technologies for benefit of patients. This time we have introduced a novel assay called as complement resolved diagnostics for allergy testing, wherein AI-based platform is used using molecular technology to diagnose the allergy. It has high sensitive and high specific, and it can be used for diagnostic, prognostics, and as well as management of treatment of the patients. I have with me in the panel Dr. Sandeep Shrivastava, who is a director of the Center of Excellence for Molecular Diagnostics and Allergy at DrBLalLab Clinical Laboratory. We have our technology partners as well, Toso India Private Limited, and we have Dr. Girish Patwardhan, who is CEO at Toso India, who will be explaining the benefit of complement resolved diagnostic assay. And we have Mr. Sanjeev, who is a product manager also at Toso India. He'll be helping with Dr. Girish to understand the test better. Now, without taking much time, I hand over the session to Dr. Sandeep Shrivastava to take it forward from here.
So thank you, Dr. Monica, and good afternoon, everybody. Due to high prevalence of allergic diseases globally, there are increasing demands in clinical practice for managing IgE-mediated conditions. Component resolved diagnosis has been introduced into the field of allergy or clinical allergology and providing information that cannot be provided from extract-based test. We all know that with CRD, allergology is experiencing a technical advancement and providing many precise and customized, personalized information to manage and properly diagnose allergy cases worldwide. So with this, I welcome you all and thank you for this opportunity to DrBLalLab, where today in this session we will explore the CRD for allergy diagnosis and management. As we all know that cases of the allergy are increasing worldwide, and they are facing since long problem for the correct diagnosis, correct guidance, and the area is vast. So there are many challenges. But just to recap on this session, we just have a quick way on this. Every 3 minute food allergy reaction sends someone to the hospital, or we can say in developed countries, more than 20% cases are allergic, um, and they are affected by any kind of the food allergy. In 2012, CDC reported that 1 in every 13 children in school, they are either food allergic. But now the incidence has been increased, and in the Lancet data in 2020, based on surveys, suggests that the 1 in 8, one child in 8 children is sick or affected with the allergy. And the cases has also been increased from 13% to 15% till 2022. So this is an alarming case, and especially post-COVID, the allergy cases has been increased. And although the subject is very old, but we can say the allergy can be categorized into 3 vast categories. One is respiratory allergy, second one is skin allergy, and the third one is other. But after COVID exposure to the public, this other section has been increased very vast and getting the category in all category in the organ. So if we see the allergic symptoms may appear right from the bottom to toe, means top to the head to the toe. In any organ, these food allergy or aeroallergens allergy can impact and create some disturbances or deviation into the life of the child or maybe the patient. If you go back to the era, more than 100 years back, the Clement in Vienna, in Austria country, he coined the allergy syndrome. And then afterwards, in 1921, antibody came into the existence as an entity to cause for the affected as a factor. And in 1965 to 67, consecutively, the IgE was rejected by Japanese scientists. And since then, if you see these antigen antibody information and IG has been exploited in a very robust way to address the allergic issues or maybe to control all those things. But still, we are facing many challenges during this to maintain the allergy or to handle or manage the allergy. If you talk about the what are the hurdles or what are the challenges in this allergy diagnosis or management, so this slide is very appealing to me because every day, in my experience and in my feedback of my network clinicians, they always find that there's a classical myth. Then the common public and even educated people, they don't consider allergy as a disease, so they don't get prompt action on that. होता है, दिस इज द लाइफ, हो गया तो ठीक नहीं होगा, दिस इज हाउ इट विल बी, पर बीमारी नहीं है, इट्स लाइफ और इट्स वे ऑफ ग्रोइंग. So that myth is the big hurdle in the allergy diagnosis or management to be taken up properly. Then the poor education about the subject, because the allergy, like in our previous slide, I told you that allergy has been coined in more than 100 years back, but till now, the allergy subject has not been independently established as a subject. So this is again the research and other activities are limiting because there's no independent or subject as allergy. And another thing, especially in India, where they take people, especially for themselves, they take themselves granted. मेरा तो जरूरी नहीं है. That's a normal thing, and even they pass time with allergic symptom, itching and sneezing, or maybe some rhinitis cases, migraine cases, but they don't bother about the time productivity and personal life. So if we show them the disease burden in terms of their disease adjusted, disability adjusted life years, then they will come to know that how much precious time they are wasting just because of not taking seriously allergy as a disease, and they are not taking good corrective action. So these are the major challenges, but of course, there are future limitations also, like the approaches between the two. In Indian setup, especially in developing countries, this first, the top-down approach has been already been appreciated and supported by the clinically driven approach. But if you talk to me, in the bottom of that, or background of this, the reason behind this, the the non-availability of the technology, and of course, in the beginning, if you go for the vast array of the allergens, then you have to pay in advance. So that money paying capacity for the early diagnosis, this mindset is not there. But nowadays, the technology-driven approach is also being emerged, especially in developed countries, where they take the holistic approach for the allergens and they then correlate with the clinical symptoms and they take forward steps so that some good diagnosis can be managed. So this strategy was also the challenge. Some limitations like the too many allergens, lack of standardized purified allergens, cross-reactive allergens, multiple false positivity due to CCD, and then no standardized allergens are available. Allergens are always have been debated, the regional, ये अमेरिका का allergen है, ये इंडिया का allergen, this is rural, so this is not going to represent right sensitization. Many individual tests has to be performed in the beginning. Then, of course, yes, CCD. These are the false positive cross reactivity they give. So the ruling out the CCDs is again a challenge. Then risk identification severity. I will come to this point in the next slide, where the risk identification of the severity is very important. And then again, the reports of clinical allergy, reports of clinical decisions, front of the challenges like numerous unexplained multiple positivity, no differentiation between genuine and cross-reactive sensitized. We cannot find this kind of information in the reports available till now, because these till now the reports whichever are coming, they are performed, or those tests are performed in the gross or the as a whole extract of the particular allergen or particular food or particular herbal. So because of these challenges and limitations in clinical practice, the clinicians have many unanswered questions like does it give details cross reaction, area of risk identified, the CCD positive eliminates or not, the clinically relevant or relevant sensitization are differentiated or not, precision medicine can be supported based on this report or not, how to make clinical decisions. So these are the many questions, even especially the immunotherapy, whether particular output or the positive allergen which has been given into the report, based on that AIT will be successful or not. So these information are not there. They are very crude information. So based on those information till now, we or clinicians have to take the decision on their own risk or hit and try. So in this all these questions, again we come to know again, do we really need the compound result diagnosis for to address all these things? Or if we take the CRD as a promotional way or in the diagnosis, routine diagnosis, then what possible benefits we may get from CRD? So these are the few questions always in the mind as a scientific community or as a clinicians. And again, when we talk about the components and the recombinant proteins or allergens, purified proteins, then again question comes to mind that do we really need to go deep down to up to the purified proteins or recombinant proteins? That much of deep down information do we require to manage the allergy, whether this will be helpful or not? So all these questions now I'm very much pretty confident that they can be answered with the CRD, because the CRD has come up with many, of course, crude antigens are there, then recombinant are there, purified and characterized antigens are there, and so we can see to address this. Do we really need to go deep down on this particular molecular level just to justify or just to make the feeling of how why this is very important to know the recombinant or purified protein status, whether this is giving the allergic sensitization or not. So these are the few cases. Just we can add this kiss of death, because this is the first. This is one case where the boy took the shellfish as a seafood dinner, and the boy and girl went to the goodnight kiss, and then girl died because she was highly allergic for the shellfish. Then again, another case like the peanut allergy. So the boy was having the peanut allergy, but girl didn't know. So they kissed each other, and after some time, anaphylactic shock appeared, and boy died. So another the team. This is again he died due to the kiss peanut butter or some lipstick that was having the peanut. So the point comes, the the whole peanut has to be avoided, or peanut is so aggressive that only kiss can or little exposure can be fatal. So these are the few questions which can be addressed by approaching diagnostic way till the molecular level or diagnostic. So we must have such tool. So because this is giving the feeling that we must have the such tool by which we can predict the severity of the allergy so that more precise avoidance would be achievable. Now coming, so with, to address, just to have a background of the CRD, because initially the whole extract has been used where the specificity is low. So now coming to the purified extract, characterized component and molecular allergen. So CRD plays role over here that contains all, because few proteins or few allergens cannot be purified, cannot be recombinated into the bacteria because of the source limitation. So that particular test has got the crude also, purified extract, characterized component, and molecular allergy. So the sensitivity of assay has been increased in like anyway. If you go to these points like the cost, specificity of true positive, accuracy, and IG profile prognosis go too high, where we will using the crude generation 1, generation 2, the recombinant and the characterized and now the CRD generation 4. So here all three are the towards the high. The important thing is the diagnostic informations are very precise. On that we can take the decisions. This is just to show the you people that this is particular the dust mite or single allergen. Earlier, all in all techniques, whether it's ELISA, AIA, or Fadiatop or Immunocap, they always use in the beginning as an extract as a whole. But now the component has, for example, in dust mite, DAP1, 2, and 10. So similarly, in LL allergens also. So CRD team or platform has all these components as individuals. Like to explain the severity also, because now we have the component where they are well characterized and identified. So in peanut, this example, we can say the CCD, this is not relevant clinically to be taken up for the management guide. Like this ARH8, this is the low probability of the severe reaction, and ARH2, high probability of the severe reaction. This is well identified. So if such kind of information if we get, then definitely the information is more strong than more strong future guidelines or future management can be done. Allergy. This is the simple experiment or case study of a boy, just to understand this particular slide, the low probability protein or high probability severe reaction protein. The boy was allergic to the extract for the peanut, but you just imagine case one where the CRD gave the results to the positive or sensitization with AR, AH1 and H2, and rest for rest it was negative. Then in this case, CRD AI supported information or characterization of these molecules suggests that these are the storage proteins and they are highly heat stable for digestion, and they create a systemic reaction and they are severe reaction like anaphylaxis can produce. So in that this case, the boy has to be in the guidelines that in those all circumstances that he or she has to avoid in any amount of the there should be no exposure for the peanut at all. Then only he will be safe. And of course, for the precautionary point of view, he or she should carry the epinephrine in case if he gets direct or indirect exposure to this one particular component. So this information will save his or her life. Similarly, if the same case we see where the peanut allergy was positive as I extract, but ARH1 or 8 were positive, and they are the heat labile proteins and they don't create the systemic reaction, the local reaction. So he may be advised that the okay, you avoid it and it is better to not to come in the exposure, but don't worry, you will not get the serious effects or serious symptoms, and then there will be no need of the carrying epinephrine also. So his life will be more confident, even he knows that he is allergic to the peanut. So this kind of the confidence and precise guidelines for the management of controlling the allergy, the CRD is quite capable for that. So we know that CRD how it is important. Similarly, for the immunotherapy, in case of the therapeutic aspect of the allergy, if we know in the beginning or in the diagnosis the particular case or patient is positive for therapy 1 or therapy 2, only in these cases the AIT will be successful. And if he or she will be positive for the rest of the, they are not AIT, but they don't elicit proper immune response. So this information and these all things are categorized and compiled by the AI, artificial intelligence platform, and of course the tools provided by the CRD concept. So this is quite handful information and strong information we are getting from the CRD. So in nutshell, if I say the CRD, this is a very promising future for the diagnosis, and maybe it will be a first choice for the clinicians to address or to control or to manage the allergy cases which are increasing day by day due to many reasons. So, for example, in this there are the 6 advanced technologies. The number of allergens they are very good, nearly 300. AI, you have the risk identification, you have the eliminate false positive or CCD is not there, improve sensitivity and automated generation, and of course AI is supported and cost efficient because we are increasing the holistic environment or holistic group of the allergens. So there will be no need to go for the further testing or further group of allergens because this has got the all information, the families, protein family, and the group and the cross reactivity. So the all kind of available proteins which have been associated with the allergy kind of symptoms or responses, they are covered in there. So once we go and screen the patient for with this, I think this will be a great tool to go forward for the more confident management and treatment of allergy cases. So this was about the briefing, the challenges, the limitation of the allergy. But yes, of course, from our side, we have also established the Center of Excellence for Diagnostics from 2019, and then we are providing, and we are ready, always ready to take up the tools and advanced tools so that the best diagnosis can be provided. For further, I think next expert will cover exactly the CRD. So this is the from my side. Next, over to you, Dr. Monica, please.
Thank you, Dr. Sandeep. That was quite insightful. Definitely, CRD has a long way to go. Now, I would request Dr. Girish Patwardhan, CEO of TOSO India, to share his thoughts on the technology, which is very promising.
Well, good afternoon, everyone. Am I audible, Dr. Monica? Is this
Yeah, Dr.
clear?
Girish, you are audible.
Okay, good afternoon once again, and thank you, Dr. Monica, for the kind introduction. At the outset, let me thank Dr. Bilal Clinical Laboratories for giving us this opportunity, as well as for taking the initiative to start component resolved diagnostics, or molecular allergology, as it is also called, for the first time in Rajasthan, in Jaipur particularly. So, this is something that is taking the field of allergy diagnostics by storm. And thank you, Dr. Sandeep. I think you have really put the subject in perspective and touched upon certain parts on the CRD and its benefit. In the next couple of minutes between Sanjit and myself, we will try and cover some of the basic aspects of the fundamentals of what component resolved diagnostics is. And then in the second part, we will also cover some of the key clinical benefits of component resolved diagnostics. So, Sanjit, can I have the first slide? So this is something which Dr. Sandeep already shared. The common approach to today's allergologist or allergist, the way it is approached and the diagnosis of allergies approach is what is also called as the top-down approach, where you start with the clinical history, examination findings, suspected allergens, then proceed for a skin prick test. If required, back it up with a specific IgE test based on extracts. And if you still don't have the answers, you move to the level 3 of testing, which is component resolved diagnostics. Pretty much in India, till 2 or 3 years ago, this was the conventional approach, and some people still do use this approach. But what is taking the Western world, particularly Europe and the American uh, allergist, is what is called as the bottom-up approach, which says you start with screening for hundreds of different allergens. So this is the bottom-up approach, and then you corroborate that with the clinical findings. If any of you are familiar with the molecular allergology user guide, which is also a 2022 edition, you can read it up. There is another approach, which is the U-shaped approach, which is you first screen for 300 different allergens and then directly move to correlating with the clinical history or the findings. In all these cases, either the SPT or the extract-based testing or the component resolved diagnostics, the molecule of interest is detecting sensitization to specific Ig. The question remains, what is it that you are detecting the sensitization against? The specific Ig is detected against what? So I would request Sanjay to quickly take us through the basic fundamentals of what component resolved diagnostics is. So, Sanjit, can you please take over?
Yeah. Thank you, Doctor. So now, as Dr. Girish mentioned, the most critical part is detecting the specific IgE. But the question is, what exactly is this specific IgE being produced against? Now, this is the major change that we are now talking about in the field of allergy, that what is considered as an allergenic source is now being considered as the allergen. So for example, if you look at the apple over here, the apple is originally considered as an allergen. But now we are focusing on the key proteins that are present within the apple that are actually triggering the production of Ig antibodies and ultimately causing the clinical symptom. So the specific protein present within the apple's pulp or present within the apple's peel that is causing the food allergy, these are the proteins of interest and they are referred to as the allergen. As Dr. Sandeep previously mentioned, that over here we have the allergenic sources on the top row, where dust mite is a source, milk is a source, and cat is a source. But the specific proteins present within the cat that are actually causing the rhinitis, causing the asthma, they are FeLD1, FeLD2, FeLD4, and FeLD7, where FeLD is nothing but the scientific name, so Felis domesticus, and the number is the order in which these allergens have been isolated and characterized. Similarly, milk is an allergenic source, but the proteins present within milk causing the food allergy, they are BOSD4, BOSD5, and BOSD8. So when we perform a conventional allergy test, over there, we are determining the specific Ig against the entire dust mite, the specific Ig against the entire milk. But when we perform a CRD test, we are obtaining the specific IgE results against the individual proteins present within each allergenic source. Now, what is the benefit of making diagnostics as specific as such? That is what we shall be discussing. Another very fascinating concept, as you all know, in molecular allergology is that of the protein families. As you can see on the left-hand side, we have multiple protein families listed, such as the tropomyosins, the storage proteins, the albumins. And within each protein family, you will notice there are multiple allergenic members. For example, in the tropomyosins, there are allergens such as penem-1, which is a very specific protein from shrimp. You have DrP10, another very specific protein from dust mites, and you also have BLAG7 from cockroach. You will realize that these are all individual proteins from independent sources, yet we are grouping them under one protein family called tropomyosins. And this grouping takes place because these allergens, they're very similar in their amino acid sequence, in their structure, and their biological function. Thus, as a result of these similarities, we can group them under one protein family. And this same concept is then applied to all the other protein families as well. Thus, when we perform a CRD test, not only is diagnostics incredibly specific to these individual proteins, but we shall also understand what protein families are present in your patient's clinical reaction. And as we shall see, the identification of the protein family plays a huge role in transforming the patient treatment and management as well. Now, just to put things into perspective, if you look at other domains of testing, for example, if you had to perform an HIV test, you would not utilize the entire HIV virus. Instead, you are identifying a very specific protein such as P24 or GP46. You're producing it recombinantly and then detecting the relevant antibodies. Similarly, if you look at COVID-19 testing, which was being done in the millions in the past few years, we were not using the entire coronavirus. Instead, we identified a very specific protein, such as the spike protein, produced it recombinantly, and then detected the relevant antibodies against that. So the same concept being used in bacteriology, virology, parasitology is now finally being applied to allergology. So if you would like to diagnose an apple allergy, why use the entire apple extract? Modern day diagnostics is incredibly specific. So let us find the causative factor in the apple, such as MALD1, which is causing the clinical symptoms. Let us produce it recombinantly and then detect the relevant or Ig antibodies against that. Thus, the idea of the CRD technology is to bring allergy on the same playing field as all the other domains. Now, coming to some of the fundamental differences between the allergenic extracts and the allergens at the CRD level. As you know, these extracts are known to have two major problems. One is the problem of false negatives, and the other is the problem of false positives. Now, looking at the problem of false negatives in this slide, you will notice that this allergenic extract contains multiple types of components. Now, you can imagine that if you have a patient who walks in and they are allergic to this red colored protein, you will notice that this red colored protein is underrepresented in the extract, meaning it is present in very small quantities. Now, if you are to run a test using that patient sample on this extract and they are positive for the red protein, well, chances are that this patient's Ig antibodies will not bind to the red protein in the extract because of the lack of red protein available in the extract or the low concentration. As a result, we will get a negative test. Now, this is a false negative. The patient is allergic, but the problem is the concentration of protein available. This problem is rectified at the CRD level by producing the very same red protein in large quantities and recombinantly. Thus, at the CRD level, you can imagine when the same sample is run, Ig antibodies specific to the red protein can easily come and bind, thereby giving us a positive result. Thus, the false negative has been converted into a true positive at the CRD level. Similarly, as you know, there are many such proteins which degrade over time in an extract, or where the epitopes are masked. Again, if the protein has degraded or the epitopes are masked or hidden, Ig antibody binding cannot take place, again preventing us from diagnosing or detecting those patients who are positive for the yellow protein and those for the blue. This is again rectified at the CRD level by producing the very same proteins in a stable format where they are not acted upon by enzymatic degradation and where the epitopes are accessible for binding. again ensuring that patients who are positive for the yellow and the blue proteins can be effectively detected and diagnosed, thereby again converting the false negatives into a true positive. Similarly, as Dr. Sandeep mentioned before, that there's a massive problem of false positives in current day reports. And as we now understand, this problem of false positivity is because of something known as CCDs, or cross-reactive carbohydrate determinants. And these CCDs are nothing but carbohydrate moieties, as you can see, which is demonstrated by the black line over here. These are the carbohydrate moieties present across various different allergens. So it is present in your pollens, it is present in your crustaceans, in your mites and foods, nuts, legumes, you name it. It is all across the spectrum. Now, 30 to 35% of the allergic population produce Ig antibody against this CCD moiety. Thus, when a sample gets added to the solid phase and that patient possesses Ig antibodies against the CCD, it will bind to the CCD in one allergen. But because of cross-reactivity, because these CCDs, they're so similar in structure, the Ig antibodies will bind to the CCDs in all the other allergens as well, because of which you will get multiple positives in your test report. But as clinical data now shows that this IgE to CCD binding does not cause any clinical symptoms. If it does not cause any clinical symptoms, it must be considered as a false positive. Thus, this IgE to CCD binding is the main causative factor for false positives in current day allergy reports. Now, how do we combat this? We are combating this in the CRD-based assay or the ALEX2 assay by using a CCD inhibitor that is present in the sample diluent. And this CCD inhibitor will basically capture up all the Ig antibodies specific to the CCD and thereby preventing them from binding to the allergens on our solid surface. Thus, in our test, we will only see those positives where IgE binds to a protein component and where a clinical disease can actually take place. This concept is very well illustrated in this example. This is a snippet taken from a research paper regarding the ALEX2 CRD-based assay. As you can see, we have a microarray test onto which 300 allergens have been coated. Now, on this microarray, you can notice multiple positives have been detected, which are denoted by the colored spots. Now, you can imagine if a report were to come to you on the basis of these positivities, you might have to advise the patient to avoid many different things. But you will notice that this microarray was performed without any CCD inhibition. And once CCD inhibition was utilized, the majority of positives have now disappeared, indicating these were all false positives where IgE was binding to the CCD moiety. Thus, in our test, where CCD inhibition is an integrated part of the protocol, we will only see those true positives where IgE binds to the protein and where a clinical disease can actually take place. Again, reducing the false positivity and increasing the clinical correlation. A massive differentiating feature in the CRD-based assay. Now, over to Dr. Girish to take us through some of the clinical applications.
Thank you, Sanjit. I think that was a very lucid presentation. Just a couple of key takeaways from what Sanjit has presented. First thing is we have to now move away from extract-based testing to molecular-based or component-based testing. Second, we must also, from a mindset perspective, we have been thinking of, allergy to dust mites. We have to now start thinking of whether it is allergy to DrP1 or DrP2 or DrP23, which are components present in the dust mites. Like, for example, in apple, we were originally of the mindset, patient is allergic or sensitized to apple. But molecular allergology brings it to the level where we can pinpoint that the patient is sensitized to MALD1 or MALD3 or MALD2. It's important to know which protein the patient is sensitized to, which protein family that protein belongs to, because there is a importance in the risk stratification. Similarly, the CCD problem, which was there earlier, that has been taken care of in this CRD platform. So, some days ago, I was attending a similar webinar where a very eminent allergologist in Europe, Dr. Lupinek, was speaking, and he described component resolved diagnostics as what MRI is to radiology, CRD is to allergy diagnostics. So, let us quickly look at, in the next couple of minutes, what are the key advantages. The first advantage of component resolved diagnostics is in what is called as risk stratification. Current day testing, which is more extract based, will say the patient is sensitized to milk or sensitized to apple or sensitized to peanuts, and avoidance is the only answer that the current day testing can allow the allergist or the clinician to make. But in these cases, if you perform a component resolved diagnostics, this is just an example I'm highlighting. If it is milk, for example, uh, current day testing would say milk, sensitization, allergic, avoid milk. But if you do a CRD and you find that patient is sensitized to, say, BOSD4 or BOSD5, which is, both are proteins which belong to certain protein families that are labile to heat and digestion. So the thumb rule in this case is in food allergy or stratification for food allergies is if the protein belongs to a family that is labile to heat and digestion, the outcome or the this risk of a systemic reaction like anaphylaxis is much lesser. So in this case, if milk sensitization BOSD4, BOSD5 is detected, these are indicators of reaction to raw milk. And if you heat the milk or you boil the milk, you bake the milk in any way, you will these proteins will be denatured, and therefore the patient is unlikely to have a reaction to the milk. However, if the BOSD8 sensitization is detected, then nothing much changes. This belongs to a protein family that is highly resistant to heat and digestion, and therefore also an indication of a severe systemic reaction. And processing the milk in any way is not going to denature that particular protein. So in this case, the avoidance doesn't change. But if you pick up BOSD4, BOSD5, then the avoidance advice can be changed. This is just a chart showing the, of course, there is one more allergen in this, but for the sake of the slide, these are the big five allergens: egg, milk, peanut, apple, and soy. We just saw milk as an example. Peanut, Dr. Sandeep already explained. Um, Now, let's take an example of apple, for example. Now, apple, Malus domesticus, as is the biological name, and 1, 2, 3, 4 are the order in which the proteins were discovered. So, if the patient is, let's say, sensitized to MALD3, and you pick up on the CRD report. Now, MALD3 belongs to the lipid transport protein family, which is again resistant to heat and digestion, and therefore likely to give a very, very severe systemic reaction. But interestingly, MALD3 is a protein that is present in the peel of the apple. So if you skin the apple, if you peel the apple, then it is safe to have the pulp of the apple. So there is an advantage in knowing which particular protein the patient is sensitized to, and therefore your advice to the patient in terms of avoidance or processing the food in any way is it can be given. Next slide. This is another very interesting advantage of component resolved diagnostics. Many years ago, when I was working with the now Metropolis Laboratory, it was Dr. Sushil Shah's lab then. A lot of Gujarati patients, strict vegetarians. We used to test them, and sometimes they used to throw up sensitizations to shrimp. And there was no way we could explain this. The patient used to say, "I've never seen a shrimp in my life. How can you give me a report which is saying sensitization to shrimp?" Now, CRD is a technology which explains this phenomena very beautifully. If we actually see the patient is sensitized to DrP10, which is a dust mite allergen. Now, because DrP10 belongs to the tropomyosin family, other individual proteins from different sources, like for example, BLAG7 from cockroach and PENM1 from shrimp, will also throw up these sensitizations. So therefore, this explains that the patient is not really neither exposed to shrimp nor is he sensitized to shrimp, but he is sensitized actually to DrP10. And therefore, cross-reactivity is a phenomena that is very beautifully explained by CRD. Next slide. This is one of another key uses of the CRD technology, and this is actually guiding multiple different things. Normally when you do a lab test, sometimes you can either screen for a disease, you can diagnose a disease, you can manage a disease, you can offer a prognosis for the disease, but you usually require multiple tests to do that. But here is a test where in a single test you can arrive at multiple different outcomes. So CRD is that in that sense is a composite kind of testing. So here is an example: dust mite, which is the commonest sensitization, 60 to 70% of rhinitis cases, or it's a very, very common sensitization. So if the patient is sensitized and you do an SPT, which is a standard regimen, which is the top-down approach, and you pick up positivity and you do a DrP1 and DrP2 after in a CRD, if both are positive, these are good candidates for allergen immunotherapy. But in the CRD, if it is revealed that DRP23 is positive, usually these are not good candidates for immunotherapy. So a certain number of cases do not respond to immunotherapy, and the reason is they are DRP23 sensitized and not DRP1 or 2 sensitized. The other key element in this chart is, suppose you do a skin prick test and you pick up no sensitization, or you do an extract based testing and you pick up no sensitization for dust mites. But if you go ahead in the level 3 testing and you do a component resolved diagnostics, if you pick up DRP1 and DRP2, these are again indications of immunotherapy for the candidate, and the patient is genuinely sensitized to dust mites, and which the current extract based or the skin prick test will not be able to pick up. Incidentally, a couple of papers in the recent past which have been published, some of the extracts which have been used for skin prick test, unfortunately, which are manufactured, do not even contain anything to do with dust mites. In fact, they sometimes contain, chickpea or candida was identified in these extracts. There are several other benefits of identifying multiple other components, like DRP5 is risk for asthma, or DRP11, which is a marker for extrinsic variety of atopic dermatitis. So a whole deal of information is sitting there, and this all comes, next slide, Sanjay, this all comes to you in a very, very comprehensive and detailed report. So apart from risk stratification, guidance of immunotherapy, cross reactivity, diagnosing accurately, CRD also offers a good amount of prognosis. So let's say, for example, um, cat or dog dander, cat dander, these are the common aeroallergens. And if you pick up FeLD1, um, sensitization to FeLD1 is a very high risk marker for the child developing asthma in the future. Similarly, if it is Aspergillus ASPF4 or F6, for future ABPA development, these are again risk markers. The other day, we were in Kolkata in a conference at CMRI, and there was a case which an allergy expert from CMC was speaking, where patient has consumed wheat and has gone to the gym, done a very strenuous exercise, and has collapsed with anaphylaxis. So this is very typically a case that can be identified with CRD, which can detect sensitization to TRIA19, which is a protein in wheat, and this is responsible for something called as food dependent exercise induced anaphylaxis. So if you pick up TRIA19, a caution has to be taken by the patient. Precautions have to be taken that after consuming wheat, he should not indulge in a very strenuous exercise or a jog or a run. So these are some of the prognostic elements that are involved in CRD diagnosis. Sanjit, can you quickly summarize the last two slides?
Yeah. So based on the clinical applications, as Dr. Girish mentioned, all of these clinical applications are finally possible by the ALEX2, which is a CRD-based platform. And it is a microarray-based test. As we can see on the top right hand, you have an image of the microarray. And this CRD-based assay is testing for 300 allergens simultaneously. So the white portion, which is your nitrocellulose membrane, you have 300 independent allergens that have been coated. You have the purified extracts, you have the characterized components, and you have the recombinant components as well. So as Dr. Girish mentioned, this is a composite test where you're getting all the layers of information. So we're getting the total IG of the patient, we are getting the specific IG against the purified extracts, and the specific IG against the molecular components. Thus, in a single test with a single patient sample, in a single run, we can screen, we can diagnose, we can give a prognosis, we can do severity forecasting as to who might have a severe reaction, who might have a mild reaction, and we can also give the clinical direction. Should you go for pharmacotherapy? Should you go for immunotherapy? Should you go for avoidance? And if it is avoidance, can you modify the allergenic source in some manner and then consume it? So all these layers of information are provided in the final test report. Thus, CRD-based assay is such an assay that is moving allergy into the realm of precision medicine, where a conventional extract-based test, if positive, would give the same standardized treatment to all the patients who came back positive. While in a CRD test, we are analyzing the patient at the molecular sensitization level, where depending on their molecular sensitization profile, the right treatment strategy will be given to each individual patient, thereby ensuring that the best treatment is given to the right patient, thus moving allergy into the realm of precision medicine. Thank you.
Well, thank you, everyone. Dr. Monica, over to you.
Yeah. So, Dr. Girish, thank you so much. Sanjeet, thank you so much. And Dr. Sandeep, thank you so much for this very insightful presentation. Complement result diagnostics on LX platform definitely is a test of the today, where not only you can give the correct diagnosis at a molecular recombinant level using AI platform, but also you can give the diagnosis, prognosis, and the therapeutic advantage in one single test to a patient. I think that solves the major problem what the clinicians are facing, where you are having a false reactivity, cross reactivity, a false positive, or false negative, and that is the only solution that you should have a this testing done instead of going for skin prick testing or conventional way of testing on ELISA or other platforms which we are having in the market. Uh, I would request a few questions from the audience if they want to have some questions around the technology and its usage.
Ma'am, Dr. Anshul Mittal sir wants to know that shall we directly go to straight to CRD in case of suspicions of allergy? Any lower age limit for CRD?
Dr. Patwardhan, I would request if you can answer this question.
Yeah. So if I get the question right, one was whether we can directly go for a CRD test, and second was, is there an age limit? Was the question, or?
Yeah, doctor.
Yeah.
Yeah. So CRD is so that's the approach that I said earlier. It's the bottom-up approach where uh, the patient can directly go. In fact, in the Western population, a lot of them do the CRD test and then consult their particular allergologist with their symptoms. And as long as there is detectable IgE, age should not be much of a factor. If it is picked up very early, also it should be possible.
There's another question from Mr. Agarwal. If patient is allergic to DrP10, will he have to avoid other allergens of a similar
Yeah,
structure?
that's a very good question, because if the patient is, if he's sensitized to DrP10, as I said, belongs to tropomyosin, he is also going to test for penem1, which is a shrimp allergen, and penem1 is a major allergen in shrimp. So if the patient is going to consume seafood and shrimp, it is very likely that he will have a massive, systemic reaction to the shrimp that he has eaten. So if DrP10 is detected, one should be very careful in the shrimp also. But this is all highlighted in the report as well. When you get these cross reactivities, this is all highlighted in the report. Incidentally, Dr. Monica, because there are 300 different allergens involved, this technology platform actually brings together four modern day technologies. So one is the recombinant DNA from the biotechnology field, the nanotechnology, multiplexing, and most important is artificial intelligence, because 300 allergens, all permutations and combinations, it is not possible, humanly possible, to remember, all the permutations, combinations, cross reactivities, families. So what the AI does is it dips into different servers which are allergen databases and which are upgraded on a real-time basis, and then gives the corresponding information in a customized format depending upon the sensitizations that are picked up in the report.
Right. Thank you, Dr. Girish. Uh, Anyone who would like to understand more about the test and technology, there are certain questions which are put up for the pricing, which we will address separately.
What is the rate of false positivity?
Uh, Actually, Doctor, the false positivity, as Sanjit has already explained, current technology platforms do not take care of the cross-reactive carbohydrate determinants. In fact, in our findings, we have found that sometimes the patient is suspected for allergies, but the report is completely negative. And previously, if you see his other older reports, and I'm not talking of things which are not done in good laboratories, but even in good labs, you will find a lot of patients reporting with multiple false positivities. In children, typically, get multiple false positives because of CCD. But because we use an inhibitor in the technology or in the performance of the test itself, the number of false positives are almost minimal. So the
Do all
specificity
labs,
of the test is very high.
do all labs which are performing CRD, they are all using this technology of
Yes,
CCD?
currently in India, we are the only ones who are selling this technology. There may be other competitors, but if you say component resolved diagnostics in the multiplex format, this is the only option that all other laboratories are using.
Right. Dr. Sandeep, there is a question from Dr. Anshul for the TAT of the testing. Would you like to answer?
I did
Dr.
not see
Sandeep,
I did not see the question. What is the
the
question?
question is the turnaround time of the reporting.
Turnaround time reporting is same day. So you can say like cut-off time, na? So it can be produced in the same day. If it reaches to the lab before 8 a.m., or 9 a.m., then it can be reported by
The same day.
the
Right. Right. So I would like to thank you all for joining in for this wonderful session under the umbrella of Doctor, and we will keep on having such sessions on a regular basis from now onwards. Thank you once again to all the panelists and all the teams who have joined here. Thank you so much.
Thank you, Dr. Girish. Thank you,
Okay,
Sandeep.
thank you, Dr. Sandeep. Dr.
Sorry,
Monica,
one
thank you.
question is also arrived. What increased total IgE is normal for kids 4 year? Will CRD test will be helpful in determining the allergies?
There's another question which has come.
I'm
Yeah.
sorry.
Question.
Yeah. So even when doctor, the question is if the total IgE is low, is it possible that CRD can still detect any allergies?
You can answer it. Okay.
Yeah, so it's a very relevant question, and time and again we have seen that many a times the patient can have a completely normal total IgE, but if you are to perform a CRD test, you will still detect the sensitizations. So it is very much possible that the patient has a normal total IgE, but actually has specific IgE sensitizations to various different allergens.
Just to add to what Sanjit has said, total IgE is not a particularly good marker if you want to screen for allergies. In a lot of cases, you will have a normal IgE and a patient is actually sensitized to multiple allergens. You can also have the reverse where total IgE is elevated because of non-allergic causes and you may not detect any sensitization. So wouldn't place too much of reliance on total IgE as a screening tool.
Yes, that's definitely because we come across and we will come across in many cases. Total IgE is like anything, 2000, 2500. Then the specific IgE is completely not responsible.
Absolutely.
So this is the beauty of the test. The total IgE is just a general response from the immune system. There are many co-founders, parasitic infection, even anxiety, bacterial infection, parasitic. Total IgE directly doesn't have any role with the specific IgE. So that is the one thing we have to always disseminate and educate.
Right. So thank you once again. Thanks you all for joining in. Thank
Okay.
you so much.
Thank you, everyone.
Have a
Bye-bye.
great day. Yeah,
Thank
bye.
you.